Hello, my name is Tabor. I'm sitting at the International Scientific Meeting in Macau with Professor Peter Dietz from Sydney, Australia. He is one of the pioneers in ultrasound in urogynecology. And tell me, Peter, what are the latest news in ultrasound and urogynecology?
Thanks, Anne. Well, I think that there's been more and more interest in pelvic floor ultrasound, and that's probably largely due to the fact that we've rediscovered a form of maternal trauma, childbirth-related pelvic floor trauma that was virtually forgotten for about 60 years. We now know that when women deliver the normal way, there is the likelihood of about 10 to 20%, and after forceps it's much higher, of doing substantial damage to the pelvic floor muscle, the levator muscle. That has major implications for the future, of that particular patient. That kind of damage is strongly associated with pelvic organ prolapse, and what's more important, with prolapse recurrence after pelvic floor surgery, pelvic reconstructive surgery. What that means is that suddenly every gynecologist, urogynecologist, urologist who's dealing with prolapse is interested in the pelvic floor, which is unprecedented, or at least should be interested in the pelvic floor. And of course, ultrasound is the primary diagnostic method for assessing the levator, because it is clearly superior to MR in that particular indication.
So you're saying that every clinician should be able to do a gynecological ultrasound to look at the levator trauma?
That may be asking a bit much for the moment, but of course that would be the optimum. Or at least I should say that somebody who does pelvic floor surgery should have access to somebody who provides such imaging, because we found that after conventional surgery the likelihood of recurrence in somebody with avulsion is close to 80%, so it's barely worth doing. And we've also found that using mesh in such women is clearly beneficial, and mesh use in urogynecology is the main topic in our field. So that means we can provide the clinician with an indication for something that is currently rather controversial. It's a form of self-protection to be able to make that diagnosis. And what's even more interesting is that we're now starting to tackle the underlying problem. That is, we are starting to repair the tears, the trauma, and we are starting to compensate for the functional effects of such trauma. It'll be another several years before we can really be sure whether that works or not, but at least after over 100 years of surgically trying to fix these problems, we now understand at least some of the pathophysiology, and we are tackling the underlying problem rather than just the symptom, and that's very satisfying.
Thank you.
Good.